Take a word, not a single word. Go on and kiss the girl.
Think about this question. Why would someone either not be interested in sex or want to avoid sex? Maybe pause it and write down your answers before we go on. Really, there's lots of different reasons. And this is where I think we need to get into our sort of detective mind because we need to figure out in what context does it make sense for people to either not be interested or want to avoid it. My own belief is that our being sexual beings is just sort of a core aspect of humanity, and so there's usually an explanation for that that lies somewhere, and we'll go into some of those possibilities. I've shared this before, but I think it applies again. In what context does this make sense? Again, a phenomenon remains unexplainable as long as the range of observation is not wide enough to include the context in which a phenomenon occurs. Failure to realize the intricacies of a relationship between an event and the matrix in which it takes place, between an organism and its environment, either confronts the observer with something mysterious or induces him to attribute to his object of study certain properties the object may not possess. So yeah, in what context would like think about that and develop hypotheses as you're working with people, and then check them out. So one way we could think about this is through the lens of the DSM, and one thing we could think about is hypoactive sexual desire disorder. So this is where there is a persistently or recurrent deficient or absent sexual fantasies and desire for sexual activity. The judgment of deficiency or absence is made by the clinician, taking into account factors that affect sexual functioning, such as age and the context of a person's life. And then it's not you wouldn't give this diagnosis unless it's causing distress to the person. So just because maybe we have in our mind an expectation about what normal looks like, if the client themselves are not saying that it's causing them disturbance, then we wouldn't give this diagnosis. The sexual dysfunction also isn't better accounted for by some other axis 1 disorder, and is not due exclusive to the direct physiological effect of a substance. For example, it's not stemming from drug abuse or medication that they're taking or some other medical condition. And that's one of the reasons, again, why we would be doing a sexual history, so that we would know about those possible intervening factors. And then, in the DSM, these things are useful to look at. Is this been something that has always existed for the person? Is it a lifelong type? Or if it is an acquired type? That really has some clinical meaning for us. And regardless of what it is, knowing that will help us to do better clinical work with them. And is it generalized? Like, do they have low sexual drive with everybody, or maybe only with their partner? This is where you might ask questions about masturbation, because if they're by themselves able to become sexually aroused, then that sort of hints that it's a relational issue rather than a physical one. Or is it a situational type? Like it's only a problem in the evening, or only a problem after a long day of work, or something like that. So you need to know a little bit about what the timing of when they're experiencing this problem. So check those out. Part of it also we should think about is, what are the messages that the person has been experiencing. For many women, it might be tied to that they haven't been given permission to be sexual beings. In many societies, there is a culture of silence that surrounds sex and dictates that good women are expected to be ignorant about sex and passive in the sexual interaction, and this makes it difficult for women to be informed or to feel permission to be sexual. Now, I was at a training giving this a while back, actually quite a while back, and someone said, that's no longer true. Now it's the reverse. Women are given lots of permission to be sexual beings. What do y'all think? Is that the same? As I'm reading some of your posts, part of me thinks, in the often conservative context in which y'all are residing, that there's still that message that sort of mutes permission to be sexual beings. But I'd be curious about hearing your opinions. some of the other things to look at is you're trying to figure out if it has an organic or a psychological cause. Now, I would also add relational, which I think is often a factor as well. But look at these things. Look at the onset, the timing, and the course of it. It gives you a hint to the origins of the problem. If it's an organic issue, then it likely has a gradual onset. It's generalized. It's found everywhere. It's persistent and it's progressive. If it's a more contextual factor, if it's a relational one, if it's tied to something psychological from a person's psychological background, then it's more rapid or abrupt. It just started after this period of time. It's more situational. It maybe comes and goes. It's more transient. That would be a hint. Now, of course, I'm going to do my due diligence, and the moment I know someone's experiencing this difficulty, I'm going to also refer them to a physician to rule out organic causes. I don't want to be treating something as if it's a psychological when it may have a very easy to address physical, like a chemical cause. So let's rule that out first before we do anything. It's again, reminder, it's our ethical duty to do that. Now, compare that idea, a low sex drive as opposed to a sexual aversion disorder. This is a persistent or recurrent extreme aversion to and avoidance of all or almost all genital sexual contact with a sexual partner. Again, the disturbance also has to cause marked distress or interpersonal difficulties. Now, think about that as a detective. There's probably some fairly common causes of this. If people have experienced traumatic sexual experiences in their past, it makes sense that they may develop an aversion. So it's sort of the difference between if someone says, yeah, I could give or take it, I don't care if we have sex or not, versus like a panic attack sort of response at the thought of engaging in sexual activity. I think it's important to distinguish about which one you're working with, because the clinical approach to that would likely differ. And then the same sort of the criteria that we talked about with the previous one. I think those are important to look at. Okay, I'm going to shift now and talk about two other common presenting problems. These were both ones that came in, but I want you to be able to distinguish between dyspareunia and vaginismus. Okay, the diagnosis for dyspareunia is recurrent or persistent genital pain associated with sexual intercourse in either a male or a female. The disturbance causes marked stress or interpersonal difficulty, and the disturbance is not caused exclusively by vaginismus or a lack of lubrication. It's not better accounted for by some other factor. You're going to rule those out. Again, you're going to send them to a physician. And I want to contrast that with vaginismus, which it sometimes gets confused with, which is recurrent or persistent involuntary spasms of the musculature of the outer third of the vagina that interferes with sexual intercourse. And it's not better accounted for like by somatization disorder or some other factor like that. So what's the main difference between dyspareunia or vaginismus? Okay, let's look at some of the medical factors. Again, I want you to be very clear that just because something does get identified as having a medical origin doesn't mean that you as a clinician won't have a job. Actually, you have some unique skill sets that physicians aren't trained in, and honestly don't have time, given the context, particularly in the United States, to spend more time. I think later on I will give you a stat about the average being around 7 minutes. I may be wrong. We'll get to that though. Okay, but some of the medical or physiological factors that can contribute to these two problems. One is infection of the genitals, including herpes or others involving the vagina, cervix, fallopian tubes, or ovaries. It could be pressure against the vaginal wall that's caused by scarring from operations or radiation treatment. So let me pause there for a second. A lot of times people do not come into therapy saying, hey, I'm experiencing a dyspareunia or vaginismus. It is more that you would go the opposite. Like you might learn that someone's going under radiation treatment, and because you're informed, you're going to ask questions about whether or not that has affected their sexual functioning. For those of you who are afraid or concerned about bringing up sexual topics, if you're working with someone with cancer, the impact of that, if you don't address that, will be that people will continue to suffer with something that is treatable because you're not asking them questions. So really think about people who clients you may be having who are dealing with some of these physical issues. Okay, it could be a tight episiotomy scar from vaginal repair after childbirth. Now they're doing far less of these than they used to, but it's still important to ask, like if someone has recently given birth, whether or not they had an episiotomy. And just a side thing from that, before they used to make incisions, but then they found that if it just is allowed to naturally tear, that it heals better. So yeah, ask questions about this to clients who've recently given birth. It could be due to a fibroid or a uterine tumor. So again, going back to ethics, if you don't request that your clients go and see a medical person, a medical consultant, then they may have something like this that doesn't get diagnosed in a timely manner because you thought it was a psychological issue when really it had this as an origin. Okay, it could be due to endometriosis. It could be that the hymen is torn or just thicker than normal. It could be a bruised opening to the urethra. Like there's a number of different activities that can cause that to happen. A few others, it could be inadequate vaginal or condom lubrication. So that's why you may ask questions about what kind of lubrication they're using. It could be that they're having an allergic reaction to diaphragms, condoms, or contraceptive foams or jellies. So maybe ask them, as you're learning about the course that this has taken, like if they had changed which contraceptive foams they're using or so forth. It could be due to dryness or thinness of the vaginal wall after menopause. This is one of the reasons I think it's important to know sort of like the life cycle of people's sexual functioning and where they are in their life cycle. It could be due to pelvic inflammatory disease. Let me just, before I go on, just say, like, we don't have to be, we're not medical, we need to recognize that we are not doctors. We are not medical doctors, at least. But we need to have enough knowledge about these types of things so that we can ask informed questions. And I think that's sort of where our duty lies. And then we need to know enough about it. So if they go to a doctor and they only are given 7 minutes with the physician, that they might be able to come and talk to you and you can be an informed person to consult with. Okay. So, I mean, I wanted you to at least know about the cycle of sexual dysfunction. This can apply to lots of the different dysfunctions that we're going to talk about in this class. But it definitely starts off in a similar way. There's a period of time where something doesn't go well. So, for example, maybe they experience a painful sexual encounter. And then the next time that they attempt to have sex, maybe they remember that painful sexual encounter, so they have decreased desire. And then because they have decreased desire, they have less arousal, which maybe leads to less lubrication, which then leads to more painful sex. And then, and so the cycle starts, but there is no actual physical issue that's causing it. It could have been that they were drinking too much that first time, or it could have been that they were under stress or in grief or any number of factors, because but then they start playing this in their mind, and then it continues. So this is an example of showing how a client can enter the cycle of a sexual dysfunction in one area, for example, decreased orgasm, and then proceed to another. Like, this is where your systemic thinking really will come into play. Okay. So how might these present in therapy? There's lots of different ways, but again, it's probably not very likely that they're going to come in and say, I'm unable to experience penetration, or I'm unable to, or that I feel pain when they're not going to start with that. This is where the implicit model is very important. You're going to invite them to be able to talk about it, so that this burden can be addressed. Think about what stories people might have about this. This is something I do with every presenting problems. What are the stories they hold about this? And because that's going to inform your clinical work as well. It could be that they have a story that they're the problem, that they're a bad person, or that there's something wrong with them, or they may have a story that their partner is not a good lover, that they're impatient, and that they're like whatever it is. Um, find out what that story is, and then if it's not a useful story, then part of your clinical work will be to come up with more useful stories. What patterns might you anticipate occurring within a system when this challenge is occurring? Now, sometimes there are instances where the pain cannot be totally eliminated from intercourse. And then what? If you have a simplistic answer to that, then slow down because there's lots of different responses. Um, and the couple, it really has to be the one to negotiate this. This becomes a crucible in which the couple has to find something that works for both of them. Now, it's a difficult topic, so people will probably just not talk about it, but it will have implications on the relationship regardless. So part of your job is to facilitate those kind of difficult dialogues. So here are some of the what I'm doing right now. If you haven't noticed, is I'm going through the 8 steps, but for this particular issue. Um, so I'm going to check. I'm checking out context. I am now looking at the individual factors that the literature suggests might play into this. It could be that there's a fear of pregnancy. It could be that there's a fear of injuring an unborn child during pregnancy. Now, as I go through some of these, you may think, well, that's silly. But remember that you have had access to education in a way that maybe not everyone has. So, of course, people can have sex during pregnancy, but you as a clinician can help them understand that and find positions that work for them and so forth. It could be due to a lack of sexual arousal and vaginal lubrication, which is caused by inadequate sexual foreplay. This is why it would be really important to know about foreplay, like what happens before they attempt to have intercourse, and is it sufficient? How do they make a decision as a couple when to proceed from foreplay to intercourse? Um, that's an interesting dialogue to have with them, and a useful one in this case. It could be aversion to a sexual partner, fatigue, or anxiety. Sometimes people have sex when they don't want to, and that's not good for anyone involved. And it can be it can be something that leads to the beginning of a sexual dysfunction. It could be that they're trying to make themselves have sex when they're exhausted, or when they're having other crises or experiencing loss and so forth. It could be due to a lack of sexual experience or information. Sometimes the worst sex is when people just don't know enough about it to have a good experience. It could be due to past sexual injury or psychological trauma that they've experienced. And it could be due to a lack of desire for their sexual partner. Now, no one is always interested in having sex in their partner, and that's okay. So we need to normalize that. I've had to work with a number of people well, pardon my language, but it's a whole chapter in one of Snarch's books where he talks about the damage that can be done from a pity fuck. So you don't, if someone talks or coerces their partner into having sex, it really does harm to both of them because it can lead to resentment and future sexual problems. So I want to help them figure out how to negotiate sex in a more helpful way. Okay, now the relationship issues to consider, or systemic considerations. What I would do is observe each partner's story and how they language the problem. Like, how did they come to decide who the problem resides with? Like, it's interesting, like to listen to you all talking about how a couple would negotiate whether or not to include oral sex, because it is really a systems problem. And for me, that issue of multidirectional partiality is so important. And so if I don't figure out how to understand and be compassionate with both sides, then I think I'm contributing to the problem. Okay. I want to understand the patterns that have developed around this problem. So when it first became a problem, what did you all do? And then, what are you currently do? I'm coming from an MRI background. I'm thinking about what have been their attempted solutions, and are they engaging in attempted solutions that are actually maintaining the problem? I want to learn about their sexual history as a couple, like I talked about previously. Sometimes people, it made sense to have quick sex at the beginning because there was a risk of getting caught. But now it's 10 years later and they live in their own place, and that attempted solution no longer is warranted. So I might have to help them figure out a new ways to be together. I want to collaborate for new definitions of the problem. So if they're saying like, well, it's because my wife is frigid or my partner is insensitive, like I want to work with them to come up with a different way of thinking about it so that new solutions can arrive. I use a lot of narrative questions. I might also do some externalization from narrative therapy, so that which is like a brief version of that is like it's kind of like a dark fog has come into your relationships, and every time you all start to find a little happiness with each other, it finds a new way to enter your home, and then I wonder what you could do to lock it out and to seal up the cracks so that it doesn't take away the love and passion that you have for one another. And what I'm doing little by little in my languaging that way is I'm creating a team of them against the problem, as opposed to a judgment game that often develops in couples. I'm going to create opportunities for new interactions. Sometimes people are just stuck in the same patterns. Like I might suggest to them, like, I'm not going to explain why, but tonight, what I would like you to do is I would like you to go out and sleep on the trampoline. And once it becomes dark, I want you to unrobe and to not to have sex today, but to just spend the night on the trampoline holding each other. Now, the whole thing I'm doing is getting them to interact in a new way, because people often try things again and again that follow the same pattern. So I just want them to do something different. Anyways, we can talk more about that at some point. I'm going to give some practical education and suggestions. I might pull out my diagrams. I might give them readings to do and so forth. Again, a lot of this is from the implicit model. And then I'm going to facilitate discussions about the lack of sexual arousal with partners, including ways to improve foreplay. And helping them to negotiate together as a couple about when to attempt intercourse. Okay. Some other common interventions that I want to talk about. One are trust exercises. A lot of the ones that you learn from the Maltz video could apply here. I'm going to do guided imagery, and I'm going to talk eventually probably about the use of dilators with one of these. Okay. So I'll give you a handout about the instructions for how to use dilators, or you can watch this again. But the treatment of vaginismus almost always requires the use of progressive dilators. The good thing about this is someone may have suffered with this for a decade, and it's easily addressed. Now, you may send them to the doctor and ask them to ask the doctor if they suggest that this might be useful. But this is also something that you can develop competence in and do yourself. You may even have some of these at your office so that you can walk them through the steps of it and help them to feel very comfortable. 7 minutes with a doctor may not be enough time for someone to be able to feel comfortable enough with this in order to address the issue. So here's the basic step. This is a picture of what they might look like. You could go to any medical supply store and find these. So okay. Oh, here's my quote. On average, a general practitioner will spend 7 minutes with each patient and will interrupt the patient within 18 seconds of the start of the consultation. That honestly is not a critique of doctors. That is a critique of the way we set up medical care. Just a side story, that is not my experience in Mexico. Sometimes we talk for 30 minutes about about family and other issues before we even get to it. I have had such a different experience in Mexico with medical care as opposed to in the US. But this is an opportunity for you all because you can spend more time with people to help people with these issues. Okay, so the first thing with dilators is to assist the clients in obtaining a box of Young's Adult, that's a name brand, Young's Adult dilators that include the smallest. There are such things as pediatric dilators but for women with vaginismus, those are not needed. The client is first taught to start to re-describe her pain using other words. And so maybe words like expanding, opening, as opposed to words that might be doing like ripping, tearing, stinging, pinching. Like the words we tell our bodies actually have a really big impact. So we want to help them use language that will change things in their mind. Instruct the clients to do 7 to 10 repetitions of Kegel exercises, 2 to 3 times a day. The exercises involve contracting the pelvic floor muscles, holding for 1 second, and then releasing. So Kegel exercises are always done just before and then after the insertion of the dilator. I'll give you a handout on this. Okay, so they do the Kegel exercises, and then the first dilator is inserted with the help of an artificial lubricant twice per day for 15 minutes. Now, you want them to start with the smallest one because you want them to start with a success. So even though at first it may be smaller than is needed, it's a psychological issue. You want them to help. You want them to feel like, okay, I was able to do this. I can now move on to the next one. Then over the next days and weeks, she'll progress to 30 minutes, and then 1 to 2 hours, and then finally she will sleep overnight with a dilator. So it's the same size. So this is something that takes place over days and weeks. Okay. After the second overnight, she progresses to the next size. So when she's able to sleep overnight with one of the dilators, then the next day she begins starting with the next one, the next size up. When the final dilator, which is usually about the number 4, is started, a decision is made as to whether the partner will come into treatment to help the transition from dilator to penis. In about 50% of cases, the partner becomes involved in the specific exercises to help with intercourse. Now, I would definitely present the use of the dilators and the explanation of how to do it with the couple, with both of them there, because I want the partner to be very supportive. Like maybe they need to take care of the kids, or maybe they need to, just be sensitive about the stress that might be involved with this. I don't want them to sabotage it, so I want to figure out what ways that might happen and then intervene before it does. Okay, I mentioned Kegel exercises. Maybe probably most of you have heard of them. If you've have given birth to a child, you've probably been prescribed these, but it's something that's good for both men and women to do. So I present this for both of them to be doing. Again, I'm treating it both as a couple issue as opposed to an individual issue. Both men and women benefit greatly from strong PC muscles. All the exercises can be continued indefinitely. Increased muscle tone results in greater sensation during intercourse for both partners. Men performing several voluntary contractions as they feel themselves getting closer to ejaculation can help them to last longer. And it has been found that the lack of orgasm in women during intercourse is very common. And the ability to have an orgasm correlates with the contraction strength of the PC muscle. So, but basically, you give them a bunch of that kind of data so that they realize it's good for both of them to be able to be doing these exercises, and it will improve their sexual functioning. Okay, the main steps are: first, locate the PC muscle, and you do that by sitting on the toilet and starting and stop the flow of urine. For both men and women, the PC muscle is the only one that can do that. So you figure out, okay, what muscle am I squeezing in order to stop the flow of urine? So have them figure that part out and then go empty their bladder. The next step is, these are actually different types of exercises you can do. Like when you go to the gym, maybe you do multiple exercises for a muscle group. One is the squeeze. You squeeze and you hold the PC muscle for about 3 seconds, relax, and then repeat the process. This exercise can be repeated often during the day as desired. Short sets of 25 are recommended. If you become sore, it's important to stop. And then this is a kind of a handout I would give them. Just like any muscle, you can overdo it, so don't overdo it. Another version is tightening, where you contract and release the PC muscle about 10 contractions at a time, depending on the condition of the muscle. And then 4 is holds. Maximally contract the PC muscle and hold for 10 seconds. At the very end of the contraction, squeeze rapidly, harder and deeper for 10 seconds. This is the same thing if you went and got a trainer at a gym. They would say, like, if you're doing curls at the last part, do one last intense one, and that will help develop that muscle. It's the same thing with the PC muscle.